to you. Please start with the introductions. Thank you.
Good evening, dear viewers and participants of this wonderful Respinar on cystic fibrosis. I, I wish and I hope and I can very well confirm that you all had a wonderful scientific feat yesterday on day one of cystic fibrosis Respinar, brought to you from IP Respiratory Chapter and a committed team of soldiers of cystic fibrosis. I would rather call them as soldiers who are who wants to win the war on cystic fibrosis in children and make them breathe free and breathe easily. While I invite today our president of the IP National Respiratory Chapter, Dr. Jagdish Chinnappa, welcome to you, sir. I will also invite my colleague in Bangalore, Dr. Eileen Kinimi, a consultant pulmonologist from Manipal Hospitals, Bangalore. Dr. Eileen, tell hi to all the viewers once. Yesterday you were the moderator. You can unmute and tell hi.
Hello, everyone. Good evening.
I have the faculties today who will be taking you through wonderful scientific journey today as well. And Dr. Sneha Varki, madam, can you tell hello and welcome to all our viewers? Unmute yourself, madam. Madam, unmute.
Hello. Yes. Hello, good evening. I hope you have a good day of learning.
Okay. Dr. Grace Paul, she has been introduced yesterday, an alumni of CMC Vellore. Now she has gone from east to west to bring everything from west to east. In one line, I'm just telling, madam, thanks to your commitment. And can you wish all of us, I do not know the time there, but you should tell all our viewers good evening.
Thank you, the Indian Academy of Pediatrics, for inviting us. It's 9 o'clock in the morning here for me and Dr. McCoy. So it's a good start for us. And it's my honor to give back to India and give back to, I feel very passionate about CF. And I feel I'm in a great role to collaborate. And I'm hoping for the best for India and our CF kids. Thank you.
Thank you, madam. We are having Dr. Karen, who is going to join us shortly. She's from Ohio. She's also going from Nationwide Clinics, and she's also going to present her deliberations today. We have Professor Dr. Sushil Kabra, who is also going to be there throughout the session and would answer to all your doubts on cystic fibrosis today. So, my dear friends, are you all ready? Ready for the show? And I want all of you to just type yes, 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 yes fast. I want 96 yes. I'll just give some time to you. This is just to charge you. Be ready for the academics, the good show. And I will tell you, my dear friends, this warm-up is for you as well as for the faculties. It's a good way. We are on day 2. Oh my God, I am seeing wonderful yes coming. Very good. This is the way the tempo is built up for a Respinar. And there lot of pains has been taken by faculties from here as well as from abroad. Nice to see all of you, even on day 2, with equal good attendance and seeing wonderful yes, 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 yes. Once that yes stops, don't type no, please. Type only yes. Fine. This is a small exercise for all of you. We will do this in workshops. You say, raise your hands, take deep breath, all these things you are doing. This is the kind of exercise that we do on webinars. Type yes, no, so that you check whether you are able to see, whether you are able to participate. Today is a special day for us. Today is the day when we will speak less, you will watch more, and we want you to ask questions. Till 12 midnight, you can continue to ask questions. Dr. Grace told that it's 9 a.m. in the morning. So she's going to sleep at 11 when it will be 4 a.m. in the morning. You don't worry about anything else, but clear all your doubts. I mean, teasing you, madam. I'm sorry. So they don't mind answering any of your questions. So therefore, I can see Dr. Karen also typing, yes, madam, I mean, why don't you come live on video and wish our viewers? Dr. Karen, please, can you unmute and come in and wish our viewers, if possible? I'm introducing Dr. Karen.
Can you hear me?
Yes, madam, please, can you on your video and just tell hi to our viewers?
It should be on, but it is not showing me yet. I'll try to deal with that technical little issue as we go forward. But hello to everyone. Thanks to Dr. Varkey, who I've known for several years now, for inviting me. And also, I'm so proud to be a part of the collaborative between Nationwide Children's Hospital and Valor and the North American Cystic Fibrosis Foundation in this partnership that we've established now for a few years. I'm honored to be asked to speak, and I will mute myself at this point and let you guys get on with things.
Okay. Thank you, madam. Just, I mean, check your video till the time that we would come back to you. Dr. Kabra sir, Professor Kabra sir, if you are there, good evening. Can you wish for all? If you are,
Yeah, good evening to all.
Video sir, everybody wants to see you.
Okay, good evening to all. And I hope you are enjoying this deliberation on cystic fibrosis. Thank you.
Thank you so much, sir. And this little warm-up exercise has made the participants to go up to more than 100. Dr. Karen, we can see you. Now it's fine. I think just unmute and tell good evening so that it will be a check for your audio video.
I'm here. I
Yes.
hope you can hear me.
Yes. Fantastic. Very good. So now, dear viewers, I feel you are all ready. But before I start day one, we want blessings and one good luck from my president, Dr. Jagdish Chinnappa. Sir, wish all of us that the day two will be fantastic science.
Yes, I think Dr. Subramania is, as usual, is ebullient self, and he has started off the session very well. We have a fantastic team today to take forward what we discussed yesterday. Yesterday, we were focusing on the diagnosis of CF and the genetics of CF and the setting up of registry of CF so that we can collect and collate all the data and see that we have all these children under one umbrella to enhance both the therapeutics as well as looking at the prognosis of these children. And this day today, we have an excellent panel which is going to discuss on the management. And I think every practitioner and 112 participants are very eager to really look at what is the current status of management of these children with CF. So with these few words, I welcome our fantastic faculty today, Dr. Sneha Varkey, Dr. Grace Paul, Dr. Karen, and Dr. Sushil Kabra. And today, feel free to also ask all your questions because the faculty will be here to answer whatever doubts you have. We also have some fantastic videos that Dr. Sneha Varkey will play a little later, which will outline the important part of cystic fibrosis and what is applicable in the Indian context. So with these brief words, I think I will hand it over now to Dr. Subramania to take over the scientific session.
Thank you, Dr. Jagdish. Very nice words from you, and thank you very much. Now we will go to the science part of it. My dear friends, before we proceed to the science, let me just take 1 second from you. Tomorrow, we have got Respinar again, but not on cystic fibrosis. My dear friends, it is a symptom. It's cough. Cough in children by none other than Professor Annie Chang. She is world authority on cough. She is the most sought after author in most of the reputed journals, books, and the attendance of the halls in all international conferences will be jam-packed when Professor Annie Chang is going to speak on cough. Tomorrow at 4:30 p.m. Indian time and 9 p.m. Brisbane time, She will be logging live from Australia. And I'll tell you, she's going to answer all your questions and call. So these participants over here, I will send you the link. Please disseminate it as much as possible to your friends. Let them all be benefited from the science. So from Indian Academy of Pediatric Respiratory chapter, our request is make this Respinar to reach out to everyone and let all of them be part of our respirology family. With these words, madam, we don't want to come in between you and science. Dr. Grace Paul, you would be opening the innings today with principles on management. She has been introduced for some of you. She's from Ohio and a wonderful human being and a great teacher. She's from US and she's enthusiastic to share her views on management and principles of management in cystic fibrosis in children. Dr. Grace Paul, over to you and for your deliberations. Welcome to India again, and thank you very much. Madam, unmute yourself, Dr. Grace. Yeah.
Okay. Can you see me and hear me clearly? I hope so. Can I start, Dr. Subramania?
Yes, please.
Oh, okay.
Please go ahead.
So once again, thank you to all members of the Indian Academy of Pediatrics for inviting me. Special thanks to Dr. Varki and Dr. Chinnappa and Dr. Subramania. And it is my honor to talk to you today about CF and CF management. And I'm going to be giving the ideal way of management. And then, we have to adapt some of these principles to our management in India. So there are some things which we can do currently in India and some things which, in the near future, hopefully we will have access to all those therapies. So the first thing is, management begins with early diagnosis. Yesterday, we had some really good information on why early diagnosis is important and how it can help improve outcomes. I'm going to be focusing a lot on pulmonary management, talking about importance of airway clearance, what are the maintenance therapies, how can we identify problems and prevent complications, focusing a lot on infection control, nutrition, and then Dr. McCoy will be talking about CF modulators and how it has completely changed the, the outlook of CF at this time, and a little bit on genetic counseling. So to start with the basics, we need to understand the pathophysiology of CF. So this is a picture of our airways, and this is our epithelial respiratory epithelium. And these are the chloride channels which allow chloride to go from inside the cell to the outside. So the main thing that happens is with chloride goes sodium, and along with that is water. So basically the thing is just, it's a transport, it's like a gate through which chloride, sodium, and water are able to go. And when there is water in the lumen, what we see is that the mucosa lining is well hydrated. So, and the basic problem in CF is when there is a problem with the mutation, there is not enough water in the tubular linings, and that causes thick mucus and a lot of problems related because of obstructive disease. So to this mutation, to this chloride channel, the gene to make it is in chloride, is in chromosome 7. And in the US, the most common mutation is F delta 508. And then we have other around 1,700 to 2,000 mutations identified. But the bottom line is, whatever the mutation, the final pathophysiology that happens is the transport of sodium chloride and water. So there are multiple different mutations. And why this is important to know is because now we have therapies that can address this. And what these class 1 and class 2 are showing is that the protein to form the chloride channel itself is very defective. And the F delta falls under the class 2. And then as we go into the other classes, there is a protein that's formed, but the gate is not clearly opened, or there are just like fewer number of gates open. So compared to this normal one, you can see how defective the other mutations are. So again, whatever the mutation, the problem is the same: ineffective chloride, electrolyte, and water in the lumen. I want to show this one video. I hope you can see this. Are you able to see this video?
No, madam. I
Okay.
think you close this and then come back to this PPT while you can open the video directly.
Are you able to see now?
No.
No.
Madam, you close the screen, stop sharing, and open the video separately.
Okay, sorry.
That's better. Video is on the desktop and is open, then you just share, please. Yeah.
So this is a short video showing the respiratory epithelium, and then you're going to see cilia on top. So you can see the cilia beating nicely, and all the water layers moving on the side, and all the electrolytes and particles moving. Here you have a nice chloride channel where the sodium and chloride is moving from inside the cell to the outside. And that's a normal one. What you're seeing now is a defective CFTR channel here. And because of that, now the movement is still there, but then the mucosal layer now becomes so much thicker that the cilia are not able to manage anymore. And then you can see when it's thick like this, there's a lot of new bacteria which love to come and live there. And that's the basic problem that is in CF. So that video is available on the CFTR website.
You can stop sharing the video and go back to your PPT, madam, please.
Okay.
Full screen, madam.
Okay, so I hope you were able to see that, but that's the basic problem with CF. You can see, because now the chloride is not moving, you get this thick mucus. And how I like to simplify the pathophysiology of CF is that it affects every organ system in our body that involves tubes. So basically our sinuses, airway passages, intestines, biliary duct, everything. When it's a tubular structure and there is a lot of mucus blocking it, that obstructive process causes a lot of irritation, inflammation. And you saw the mucus, that's a big host for infection. So that's like a vicious cycle. And then we tend to see like the post-obstructive defects that are, we are not able to have enough enzymes secreted, not enough water secreted. So that's the basic problem that happens with CF. And because of that, every body system is affected. So the main thing that we see is the lungs, but the second biggest thing is the intestine. So you are aware of meconium ileus, which is very common at, that's the reason we asked for the question, did the baby have a bowel movement within 24 hours? And then you can see pancreatic duct can be affected. The male infertility is because of, again, a tubular structure that's affected. So similarly, that simple problem affects every organ in the body. So again, specifically related to pulmonary disease, you have the abnormal CFTR, you have very thin liquid there, and now the cilia are not able to balance that thick mucus. So the main 3 points are inflammation, there's a lot of infection, and airway obstruction. So you can see a lot of inflammation here. The predominant cells here is neutrophils and neutrophilic inflammation. And why this is important is there's a therapy that sort of targets the DNA of the neutrophils. So you can see how thick the mucus is. So imagine this patient every day, this is constantly forming this thick mucus. And so our goal of therapy is, one is to sort of thin it by hydrating the mucus. And second thing is we want to sort of do chest therapy. So you can move the mucus from the bottom of the lungs to the upper airways so the patient can cough it out. Here are some images of severe lung disease from one of our patients. You can see how much of bronchiectasis is there. This is actually a young, like a child who, unfortunately, there's some issues with non-compliance, and that's why the lungs look so bad. And along with that, her weight is down and her pulmonary function is also down. When we do bronchoscopy, this is something sort of typical of what we see. There's a lot of inflammation. It's the same thing. And once we suck out the mucus, you can see the thick mucus there. And we treat the patients with antibiotics, then they do better. And then this is a pathology specimen of how bad the bronchiectasis is. So this patient obviously had a bleed, and then you can see all the pus cells. So this is what the lungs look like. And so our goal is to prevent it from getting to so much damage. So the two main things that we can do to help reduce our lung damage is airway clearance and good medications. And then the other thing is, important thing is nutrition. So I know Mr. Hari is going to talk in detail about airway clearance, but what we use and stress a lot is hand chest therapy. And then we have access to this vest. This is the equipment that we have. And a lot of new handheld devices called the Acapella, Aerobica. And even if we don't have anything, we really stress on exercise. Like huff coughing. There are very specific details on each of these at the CFF website in case anybody wants to get a little bit more in-depth information on this. I'm showing this slide just to show all the medications that are currently available. And there is a very good research pipeline where we have medications for nutrition, anti-infective, anti-inflammatory, medicines for mucociliary clearance. And now we are trying to deal with the basics of actual CFTR dysfunction. So Dr. McCoy is going to talk about this part, but I'm going to talk a little bit on the other current medicines. Each of these has taken like many years, 10, 15 years to come to where it is being approved and being used now. So even before these were available, the main things we focused on here also was good nutrition, good exercise, and chest therapies. Showing the slide again to emphasize inflammation, infection, and obstruction. So we have very good guidelines from the CF Foundation on, for chronic maintenance. So one is airway clearance therapies. What are the medicines that can help hydrate the airway so that you can loosen up the secretions that can come out? The big one is, hypertonic saline, which is, again, improves hydration, helps clear mucus. I know in India right now we have 3% available, and that's something, which can really help with airway clearance until the other medicines are available. Dornase alpha, also known as pulmozyme. So I showed you how thick that mucus was, and that one, when when the neutrophils break down, they release a lot of like DNA, and this causes the mucus to be very thick and viscous. So Dornase alpha actually breaks up that DNA, so again thins the mucus. And then we use bronchodilators. One is to truly bronchodilate. The other thing is also it increases the ciliary beat frequency. So because of those reasons, we use these three medications along with the chest therapies. Anti-inflammatory, I know azithromycin is available in India also, and we tend to use it here. It has immunomodulatory, anti-infective, and anti-inflammatory properties. And it's specifically recommended for those who have Pseudomonas colonization and bronchiectasis. And it has been proven to reduce CF exacerbations, improve lung function, and reduces the pathogenicity of Pseudomonas, because Pseudomonas has this tendency to cause biofilms, and it's very hard for antibiotics and everything to penetrate. And it does have some antiviral effect also. And then we can use it from 6 years onwards, although, there has been trials showing that we can use it even younger. This is the current dosing. We do monitor for some of our patients before we start it. We test them for non-tuberculous mycobacterium. The other anti-inflammatory are high-dose ibuprofen, which is not really popular in the US because of the renal issues, but it can be used in the slightly older age group with a better FEV1. And inhaled corticosteroids, some of our patients have airway reactivity, so they benefit, and those who have ABPA also benefit from inhaled steroids. The third thing for maintenance therapy is the anti-infective or the antibiotics, inhaled antibiotics. Again, we want to keep the Pseudomonas under control. And the common things that we are using is tobramycin, which comes as a, with a specific nebulized kit, or we use it as a dry powder. It's called Toby Podhaler. Or the other one is called inhaled aztreonam or Casten, and it comes with a specific apparatus also to help inhale. So these are things which patients are on daily, or we do cycled, 1 month on, 1 month off, so we can do that. And it has been proven to reduce the number of CF exacerbations where the patient would actually need antibiotics for a treatment course. So the daily care does change with age. In an infant, there's a lot of focus on nutrition, and we can do hand chest therapy. We emphasize on vaccines, and some of the one modulator is approved for up to 6 months of age. And then depending on the gene, younger children again focus on good nutrition. We are able to start the West once they are above 1 year of age. And then gradually we start hypertonic saline, pulmozyme, and prophylactic tobramycin. And then some of the gene modulators are available. So these are daily medicines. And as the child becomes older, again, now there are other problems happening. Some of them are risk for liver disease, diabetes, or low BMI, things like that. So we address that specifically, and we increase our number of medicines gradually. And then some, after 6, they can get chronic azithromycin. This is an image just showing how life with CF is. And at a younger age, she has her vest, she has some medications, enzymes, some multivitamins, things like that. But this can be the daily treatment burden for an older, like an adult or a teenager. So you can see how much dedication is required from the family and the patient to do all these medicines on a daily basis. So we should give credit to the patients who are very compliant. So because it is very hard. Just briefly talking on CF pulmonary complications. These are the 4 main common ones. So this is a case of a patient who's 18 years old with a good chest X-ray, and then he suddenly comes in with weight loss. His pulmonary function is, normally he's in the hundreds of FEV1 and he drops significantly. What you can see is some X-ray changes. So what he is currently experiencing is an acute CF pulmonary exacerbation. And then that is one time. This is another patient who has been sick a lot, multiple times, and it sort of correlates with him dropping off in weight and not really like, nutritional status is also dropping. So there are guidelines for CF pulmonary exacerbations. So the main thing we do is we trial outpatient antibiotics. If that fails, then patients get admitted to the hospital. They get IV antibiotics, targeting what the bacteria is. This graph shows that with age, there is a change in the organisms that are that affect a patient. So based on cultures, which in our institution we do every 2 months, we can target our therapies, and we target our therapies based on the growth over at least the past two years. We increase our airway clearance, and then supportive care depending on whether they are sick enough to need oxygen and things like that. Another complication is pneumothorax. You can see here. And then it happens in only 3 to 4% of patients, and we generally monitor them, supportive care. Sometimes, rarely, they would need a chest tube. Hemoptysis, the most common reason is an infection. Here is one of our patients who had, came in with small hemoptysis, and then you can see it on the CT scan also. About 9 to 10% of CF patients can have it, but most of them it's very mild, and it is basically because of the bronchial artery that is hypertrophied because of chronic inflammation. Again, the CFF has given us good guidelines on what do you do with chest therapies. So the reason is if there is bleeding, do you want to really shake the patient's chest to help with airway clearance? You don't want to dislodge clots. And then some of these medications are can be irritant to the airways, like the hypertonic saline or the pulmocine. So there are guidelines on what do you hold, how long you hold these medicines, how do you safely restart each of these medications. And then all of these patients are observed in the hospital and they're given IV like antibiotics because of infection. This is a picture showing arteriogram, bronchial arteriogram, and then the patient actually underwent coiling. So you can see that the bleeding is now controlled. Some of our patients, we are seeing more and more in adult patients, but I know this is commonly seen in like younger children in India. And so having advanced CF lung disease. So we do continue basics of CF care, nutrition and things like that. Oxygen, sometimes they need only at night and then it progresses to day also. There is some benefit with BiPAP. Our institution, we put a lot of emphasis on pulmonary rehabilitation, which has shown good effects on nutrition and endurance, things like that. We do assess for pulmonary hypertension, and then end of life care. Our palliative team is very good, and those patients who are eligible some of them can be eligible for lung transplant also. This is just showing a patient who with severe lung disease, and then you can see post-transplant how clear the lungs are. Patients recover so fast, they are intubated for about 2 days and then they are extubated. It's a new life for them. It comes with its complications, but tremendous change in lung morbidity. Again, we a lot of emphasis on infection control because you saw the thick mucus, it loves bacteria to come in. So patients with CF are susceptible to more and more different types of bacteria, even at a younger age. We do worry a lot about cross infection. So that's why there is a big thing on 6 feet rule, social, like a sort of distancing between patients. So all the things that we follow in COVID right now, we are already following for CF in distancing patients, policies on group restrictions, mask, waiting room policies, everything we do. The cross infection with some of this bacteria can lead to worse morbidity. So, once if these patients are identified to have these problems, there's some extra precautions taken. Nutrition. So we have seen this image before. What we are seeing is higher the body mass index, higher the lung function. And so we focus a lot on nutrition. So from an early age, from the time of diagnosis, our dietitians are very, very careful about how the child is growing and what are the parameters to assess and follow. And we want to make sure that they're getting the right amount of enzymes, focus on breastfeeding, all the calories, vitamins, and fatty acids and salt. And then if they are still not able to maintain their weight despite all our efforts, then the patients go on supplemental feeding by mouth. And if still not able to do it, then G-tube feeding. I'll talk about G-tube feeds in a little bit. GI manifestations, the biggest thing we see is pancreatic insufficiency. Again, it is because the mucus is thick in the pancreatic duct. So now we cannot get those enzymes to be released. And nutritional failure. They can have vitamin A, D, E, and K deficiency because these are fat-soluble vitamins. And then with testing is with fecal elastase, and treatment is enzymes which start, from like birth onwards. Other issues are malnutrition, liver disease, reflux, and constipation and intestinal obstruction is a common issue. So G-tube feedings, I know yesterday there was questions on this. There are again guidelines on when a patient would be eligible. And this is one of our patients who was struggling to gain weight and then actually got a G-tube around this, around 10 to 11 years of age. And then, you can see the improvement. It's still not like remarkable, but there is definitely an improvement. And this takes a lot of group discussions, and it's a informed decision from the parent. We assess the social situation of the family, ability to take care of the G-tube, other complications, things like that. With continuous tube feeds, you have to dose the enzymes correctly, which can be difficult. And now recently we have this thing called Realizorb, which is a cartridge with enzymes. So the formula goes in through this one, and the enzymes are sort of constantly released. So it's very convenient for the families, but again, it is expensive, and we sometimes face some insurance issues. Diabetes is common here. You can see that as you age, more and more diabetes, and it's a sort of a combined type 1 and type 2. If somebody has diabetes, the chance of lung function decline is higher. And then we diagnose by starting to do glucose tolerance tests from 10 years of age. And then the treatment is insulin, the different types. The oral medicines are not effective in CF. Liver disease, again, some patients may have isolated liver problems alone, and a lot of lab abnormalities we see with like higher ALT and AST levels. Gallbladder disease is very common. We do liver function tests, ultrasound, other specific images, and we always monitor when we are starting any new medications because of how the medicines are metabolized through the liver. So especially antifungals or the CF modulators. And then focus on nutrition. Patients are started on ursodiol. Some of our patients do end up getting liver transplant. Now we have a hepatologist as part of our CF team. With bone disease, again, it's a multifactorial reasons why a patient would have low bone density, malnutrition, insufficient diabetes, glucocorticoid use, and then the prevalence of bone disease directly correlates with severity of lung disease and malnutrition. So patients do get a DEXA or a bone density scan, and then can be treated with vitamin D, calcium levels. We encourage weight-bearing exercises, and some of them, if they're really not doing well, we refer them to endocrine, and then they can get started on bisphosphonates. A sinus is something we commonly see. You can see all the thickened sinus mucosa, and this patient actually has a nasal polyp. So ENT surgeons are part of our clinic, and we refer patients early, we image them early, and we start them on some sinus rinses, intranasal steroids. Some of the patients get sinus surgeries, sometimes even even up to once in 1 to 2 years, and then nasal polypectomy. Mental health is a big focus. Currently, high prevalence of depression and anxiety. I know Dr. Kabra showed that this is seen even in Indian teenagers. Not only for the patient, but also for the caregivers. So again, a lot of focus on early identification. We have very good screening tools. We have a good mental health team who provide counseling, and then we have contacts with psychiatry and psychology. We have to be wary of drug-to-drug interactions with all our psych medications. Reproductive issues, again, it's because it's an obstructive process. We can manage this with some in vitro fertilization. Even among our CF patients, we have, the second generation, some of them without CF, some of them with CF, the children are with. And usually there's a slightly higher risk for gestational diabetes. And then we focus on genetic counseling and testing. So after all this, the survival, basically early diagnosis, early management has definitely improved survival. In 2016, it was 47. I don't have an updated number. It's probably like 50 and higher. And in this graph, what it's showing is earlier we had 70% pediatric kids and only, around 30% adults. Right now we are seeing sort of the reverse, where there are more and more adults living longer, getting married, working well, studying well, and actually like contributing to society. And now with the new medications, again, there is so much hope for CF in the Western world at this time. But my hope and my goal sometime is that it would be translated to other developing nations also. So in conclusion, CF involves multiple organs. Simple way to think of it is thick mucus affecting tubes in our body. There is great importance. We place a lot of emphasis on surveillance, prophylaxis, early treatment. And there's going to be detailed discussion on airway clearance, nutrition, and CF modulators. And if anybody has any questions and like really good teaching videos, cff.org has a lot of information. So thank you once again, and I'm happy to take questions now, or I can wait till the end to take questions.
Madam, can you stop sharing the screen? I think what we can do today is that because there is going to be videos and raise a lot of questions, I would just quickly take a couple of questions because there are a small number of them, and then we can go from concept to concept. Madam, quickly, it would be more or like a rapid fire for you for want of time. Will N-acetyl cysteine help or no?
So we do use it in the hospital when patients are admitted. It can cause a lot of bronchospasm, so we want to monitor that. Some of our patients do benefit even at home, but it's not our first line of medicine.
Okay. And Dr. Bharat Reddy from Bangalore has asked this question, that question on Dornase and hypertonic saline. His confusion is on the age. Is it infancy or beyond infancy?
So both can be started in infancy. Hypertonic can be started even earlier, like 3 months onwards. The Dornase, we wait at least 6 months. But earlier it used to be much older kids, but now we can do it much younger.
IRT screening test, timing of it. There have been questions on that. Should we do it in newborn period, later, etc.?
So yesterday,
but you can repeat it for benefit of everyone.
No. I got this question yesterday also. IRT is best until 4 weeks. Beyond that, it has not been shown like what are normal IRT values for any other age. But ideally at birth and then within 2 weeks would be the ideal if you're doing an IRT screen. But beyond 4 weeks, there is no benefit on that.
Okay, madam. This question is very specific. In children with failure to thrive, when will you consider feeding gastrostomy? I don't know why this question is asked because there is problem everywhere. I don't know how the feeding gastrostomy would solve.
So, again, it is a big decision, which, we follow the kids every 2 months. Sometimes we have home visits and weekly weight checks, and we follow the trajectory. And if oral feeding is not sufficient, then we do all the high calorie like formula, I don't know, like I remember Complan in India. So something like that, like really high, much higher calorie. And then even after that, and if the patient is compliant, still we're having issues with weight, and it's also affecting lung function and admissions and things. It's a collective decision. We do get kids on G-tube. We have toddlers on G-tubes and who has started on with G-tube feeding as a 1-year-old, 2-year-old. Some of them are even as teenagers we have started. Okay. So it's very, again, personalized, patient specific.
When will you consider polysomnography in CF children?
So I think generally the older, so for the younger kids, like, any other child, if they have like obstructive sleep apnea symptoms, because of tonsils and adenoids, that is there. But otherwise, it's for the older adult patients mainly when they're having like lower pulmonary function testing, lower endurance during the day. Then we want to see what is happening with their oxygen and nocturnal desaturation.
No, the question is, will you do specifically or will you do as a part of routine workup of, entire evaluation of the system?
So I don't think we have specific timing for sleep studies based on CFF recommendations. I can check with Dr. McCoy also, but then it is, again, patient specific, generally towards the older age group.
Yeah. The next question is, if they go for lung transplantation, which is a dream, of course, and will it happen in transplanted lungs, or what is next after
So you're
transplant?
asking if the CF disease
In
happens in
CF
transplanted
children
lung?
undergoing lung transplantation,
So
and will it recur in the transplanted lung or what?
no, so I don't think the lungs are fine, but the rest of the body still has CF. So, but that is one thing. The second thing is you are trading now a CF disease to an immunosuppressive disease. So, we have to be careful. We do monitor patients very, very closely. The CF transplanted lungs had the best outcome, but still, 5-year mortality is still high for CF. Some patients do great, some patients do not. So
What is the age for gene therapy?
I mean, if you mean CF modulators,
Yes.
it again
It's going to
depends
come next.
on, what's it?
That's going to come next.
Yeah, it again depends on the specific mutation, and each one is at different ages, but one medicine can be started from 6 months of age. There is one of them.
Madam, quickly, I will come to the last question, couple of questions. Do we have low cost West available in India? VEST.
Yeah, so I know right now we do not have, but then that would be my dream, because I think our Indian scientists are brilliant. So if they could create one, that will be awesome. But right now, I don't think it's available. But
Madam, for want of time, quickly answer to me. Does oral N-acetylcysteine, will it help? Yes, no. Oral.
Oral N-acetylcysteine, no.
No.
I don't think
Okay.
so. No.
Role of mannitol and ibuprofen and risk of bronchospasm.
High risk of bronchospasm. We don't use it that commonly here.
Okay. Adverse effects of 7% saline.
Bronchospasm and airway irritation with bleeding.
When CF is not a disease of bronchospasm, how does a bronchodilator help?
The ciliary beat frequency does improve that one.
How, madam?
How? I do not. I have to look that up. Sorry.
Okay, no, I'm just coming. I want to get the best out of you, and
No, I'm available, so you can ask me. Yeah.
Yeah. No, I'm just asking. I'm just transferring whatever they have asked in the chat.
No, I'm available to answer questions. So.
Okay, fine. It was very nice because I don't want to keep them starving, with that enthusiasm, and therefore I was interrupting with some of the questions to you.
No, that's completely fine.
Dr. Grace, madam, in a lighter vein, you have gracefully answered all of them. And thank you very much for being so nice to our viewers and all of them. And I'm very happy that they're asking questions. So we will ask them. If anyone wants to join and raise your hands, then we can allow you at the end, please, not in between the sessions for want of time. We will allow you to come into the panel box of the faculty, ask questions and go back. But raise your hands at the end, please, because there may be comments and then we may not be able to finish the sessions in time. So with these couple of remarks, we will thank Dr. Grace Paul. Thank you very much, madam. Be in the panel box. We may have many more questions to come as and when they come, we would take it up. Thank you very much, madam.
Okay.
We'll go to the next.
Thank you.
Okay. We'll go to the next session, which will be a lively session. It is demonstration. You have wonderful scientific treat for your eyes. You can see how exactly airway clearance is done. A lot of videos, lot of things to watch, how the team works. It's a multidisciplinary team management, and we have the team from Vellore to take care of and take you through the journey of how this committed team works, and to bring the team to you, to your doorstep. Now we have Dr. Sneha Varki, madam, and all of you. She is responsible for today's and yesterday's workshop. And I want all of you to type congratulations, 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 congratulations while madam will upload her presentations. Please type congratulations to Dr. Sneha Varki. Cheers. In the chat box.
Thank you, Dr. Subramaniam. Can I start?
Yeah, please go ahead, madam.
So the next session, we are going to discuss about two important aspects of CF care. So this is where we need a lot of commitment from the family, the parent or the caregiver. One is the airway clearance treatment and the other one is nutritional management. So these sessions were pre-recorded to avoid any technical glitches, and I really hope we won't have any right now. So in this session, the first session, Mr. Hari Pratap Reddy, he is our respiratory therapist, will demonstrate how we can combine chest physiotherapy techniques with postural adjustments to clear the airways of the thick mucus, which Grace has shown. And this has to, unlike other diseases in which there is bronchiectasis, we start chest physiotherapy when we identify bronchiectasis, whereas in CF, it is prophylactic, it's preventive. So we start from the time we diagnose CF, we ask them to do this because we have to move this mucus out of the airways. That is extremely essential. So this will be followed by the demonstration of use of vest or high frequency chest wall oscillation equipment. This was donated to us from the Nationwide Children's Hospital. We are thankful for that, and we can see this now. This also will do similar work as the percussing hands, but it saves time for the caregiver, and it is also useful for older children and adult CF patients because it eliminates the need for help from a caregiver to give the daily treatment. After this, Mrs. Jivita, our RT, will show various breathing maneuvers, how we can breathe in certain ways to use the airflow within our airways to move the mucus. So that will be the next session after that. And also we will see how a cappella, which is a handheld device for airway clearance, is used. So this is a very useful tool for not only for CF, very good for PCD or primary ciliary dyskinesia patients and other patients with bronchiectasis. Hari will be demonstrating that. After that is over, next is nutrition. And it is very important, especially in the early stages. Ms. Shinsi John, our TF dietitian, will address various components of this and explain use of pancreatic enzyme replacement therapy. So the purpose of demonstrating all this is, in all developed countries, these are individually taught to the patients and these are closely monitored. But in India, access to this allied health professionals trained in CF care is very limited. Not many people can access the service of one. So then it becomes the responsibility of the primary doctor, the pediatrician, the pulmonologist, whoever is treating the patient to take on some of these roles and teach their patient and also monitor the patient. So, we wear many hats as doctors. So we need to learn some of this from, we are demonstrating some simple techniques which we can learn and do for our patients. There are many more things a trained professional can teach them. If it is available, if the services are available, we must definitely use them. But if it's not, some of these basic techniques we can learn and teach our patients. And this basic treatment is the cornerstone of management. So I hope this demo will serve as an introduction for you into the airway clearance treatment. We will try to play the video.
I'm Mr. Hari Pratap Reddy, CF Respiratory Therapist, CMC Velo. Now I'm going to show demonstration on postural drainage positions for chest physiotherapy. Chest physiotherapy or chest percussion is a technique to loosen or mobilize the secretions which are present in the lungs or in the airways. In postural drainage, we use gravity to drain secretions from upper level to lower level. There are do's and don'ts. Do's. Chest percussion must be done in empty stomach or 2 hours after food. Chest percussion should be done on a child wearing soft, light clothing like t-shirts. We should remove tight clothing, buttons, zippers, jewelry around the neck, vest, and waist. Caregiver who is performing chest physiotherapy should remove his rings, bracelets, and watches. Before doing chest physiotherapy, we need to follow hand hygiene. And we need to keep some materials needed before doing chest physiotherapy, like sputum cups, pillows, towel rolls. So chest percussion is nothing but a clubbed hand where you need to percuss on the chest. So when you percuss, you need to hear a hollow sound. Only if hollow sound is heard, it means your technique is correct. Chest physiotherapy must be done in extended arms, not in flexed arms in children and adults. Now, I'm going to demonstrate postural drainage positions on right side. First, apical segment of upper lobe, right upper lobe. For that, we need to make child to sit in straight position, and you need to have a cupped hand, and you need to clap on collarbone for 2 to 3 minutes. This is for apical segment of upper lobe. Coming to posterior segment of upper lobe, you need to make child to sit, and on the hips, on the thighs, you need to keep 2 to 3 pillows and make child to extend his arms and slightly flex till 30 degrees, where you need to clap on posterior aspect of the upper chest. You need to clap for 2 to 3 minutes. Coming to anterior segment of right upper lobe. For that, you need to make child to be in supine lying, one pillow under the head and one pillow under the knee joint. And you need to clap on upper portion of your chest for 2 to 3 minutes. You can do percussion on upper lobe with both hands. Coming to middle lobe. For middle lobe, you need to make child to lie in supine lying and keep one pillow under the hip and two pillow under the legs and slightly elevate it unto 45 degrees where it is elevated, and you need to clap on mid portion of the chest for 2 to 3 minutes. Coming to anterior basal segment of lower lobe, child should be in supine lying, keep one pillow under the hip and 2 to 3 pillows under the legs in order to elevate. And you need to clap on lower portion of your chest for anterior basal segment of right upper lobe, right lower lobe. Coming to lateral basal segment of right lower lobe, just you need to tilt child in 90 degrees, keep one pillow under the hip and 2 to 3 pillows under the legs, and you need to clap on lateral portion of the lower chest. Now, posterior basal segment. For posterior basal segment, you can turn child in opposite direction, or you can turn towards other side and you can clap on lower portion of the chest. You need to do for 2 to 3 minutes. In every position, you need to do percussion for 2 to 3 minutes, followed by vibration. Vibration is a shivery movement where you're moving secretions from lateral to medial. From lateral, you're doing vibration and getting secretions from lateral to medial, followed by huffing and coughing to clear out the secretions from the lungs. Coughing can be taught to child at younger age itself. In infants, there is no much difference between the postural drainage positions between children and infants. In infants, we need to avoid head-down position in order to prevent gastroesophageal reflux. In infants, chest percussion with cupped hand is replaced by 2 fingers and percussor. Now I will be showing postural drainage positions for right side. We need for right upper chest, we need to make child sit in straight position. With one hand you can hold it, with the other hand with 2 fingers you can clap on upper chest in front. For upper chest back, you can make child to sit in opposite direction and hold with one hand, and you need to clap with 2 fingers on upper chest. Coming to lower chest, we need to clap in upper, side and lower. For lower portion of right lung, you need to make child to supine lying, and with one leg you need to slightly elevate, and you need to clap on anterior portion of right lower chest. You need to clap for 2 to 3 minutes. And for lateral thing, you need to slightly turn the child and elevate at the legs and you need to clap on lower portion of your chest. For posterior, you can tilt the child in other way and make child to be in prone lying, and with one leg you need to elevate slightly and clap on lower portion of your back. Thank you.
Madam? Okay, madam?
Yes,
Next.
yes, we are showing.
Yeah.
Is it visible?
Yeah.
I'm Jivita. I'm working as a cystic fibrosis respiratory therapist. Today, I will be teaching 3 exercises for airway clearance therapy. First, pursed lip breathing exercise. I am Jivita and I'm working as a cystic fibrosis respiratory therapist. Today, I will be teaching 3 exercises for airway clearance therapy. So first, pursed lip breathing exercise. Second technique is effective cough techniques. Then the third technique is active cycle of breathing technique. First, we'll see about pursed lip breathing exercise. Pursed lip breathing exercise will help to improve and control your breathing in several ways. It includes relieving the shortness of breath by slowing the breath rate. It keeps our airways open for a longer time, which decreases the work of breathing, and mainly it helps to improve ventilation. So the technique is sit straight with your back or lie down. Take a slow breath through your nose. Just keep your lips like a fish lip, then breathe out gently. So we should breathe in through our nose for 2 seconds. We should keep our lips like a fish lip, then we should breathe out for 4 seconds gently. So I will demonstrate the technique. In this technique, just make sure your upper chest and shoulders should remain relaxed. Now we'll move on to next technique called effective cough techniques. It consists of 2 techniques, normal regular cough and huff coughing. So normal regular cough. Patient can do normal regular cough, which is used to clear secretions from the larger airways, which is already there in the larger airways, will move out. So it is very important to do effective cough during chest physiotherapy sessions. One problem with strong cough in cystic fibrosis children is it can cause collapse of very smaller airways and mucus can get trapped. So to avoid this, we need to use another method of effective cough called huff coughing. So now I am going to do a technique. Now I am going to say the technique and demonstration of huff coughing. So huff coughing is mainly used to move mucus from the smaller airways to the larger airways. So the technique of huff coughing is sit straight with your chin tilted slightly up and mouth open. Take a slow deep breath through your nose. Hold your breath for 3 to 4 seconds. Then we should exhale forcefully but slowly in a continuous exhalation, so that the secretions will move from the smaller airways to the larger airways. We need to repeat this maneuver for 3 to 4 times. Then followed by, we should do one strong cough to clear the secretions from the larger airways. So now I am going to demonstrate you the technique of huff coughing. We'll move on to next method of breathing exercise called active cycle of breathing technique. Active cycle of breathing technique is the group of exercises when done sequentially to helps to clear the secretions out. Okay, it consists of 3 main phases. First phase called breathing control, which is mainly helps you to relax your airways. The second main phase called deep breathing exercise or thoracic expansion exercise. In this phase, we take a deep breath and hold the breath at a maximal lung expansion so that the collateral airways will open and air goes behind the mucus and push the mucus to forward it. So now we'll see one by one. First we are going to see about breathing control. The technique is sit straight, keep your upper chest and shoulder in a relaxed manner, rest one hand on your stomach. As you breathe in, we should allow your hands to rise gently up and we should breathe out gently. So I'm going to demonstrate you the technique. Just make sure your upper chest and shoulders should remain relaxed. We should breathe in through your nose, then breathe out through your mouth, like a fish lip method. Okay. Then we'll move on to second technique called deep breathing exercise or thoracic expansion exercise. In this technique, we should take a deep breath, then hold your breath for 2 to 3 seconds. Then we should breathe out gently without forcing the air out. So I will demonstrate you the technique. To complete the active cycle of breathing technique, we should do these breathing exercise together, and first we should do breathing control for 20 to 30 seconds followed by 3 to 4 deep breathing exercise. Again we should do breathing control for 20 to 30 seconds, then followed by 3 to 4 deep breathing exercise. Again we should do one breathing control for 20 to 30 seconds. At last, we should do one huff coughing and one strong cough to clear the secretions from the lungs.
I am going to demonstrate the use of a device. I am going to demonstrate the use of a device to aid clearance of secretions in the lungs. This can be taught to children above 6 years of age. This device has properties providing positive expiratory pressure and vibration. When child blows, a small part in the a cappella rocker moves in seesaw fashion, creating resistance to the airflow and creates positive expiratory pressure and vibration. This pressure gets transmitted into the airway, keeping the small airways opened and pushing the mucus upwards. Vibration will help to loosen the secretions. Now I will be showing the demonstration of how to use a cappella. Before doing a cappella, you need to follow hand hygiene and see that a cappella is completely dried. Before using a cappella, you need to do breathing control for 4 to 5 times. Then you need to perform. Before performing a cappella, you need to fix a resistance dial between 1 to 5, which will be fixed by your respiratory therapist or physiotherapist. So first, you need to take slow, deep breath, but not until total lung capacity. And you need to hold your breath for 2 to 3 seconds and then keep the mouthpiece in between the teeth, and you need to have a tight mouth seal in order to feel the vibration in your chest, and you need to blow in a medium speed for 4 to 5 seconds. Now I'll be showing you need to take slow, deep breath. So you can place one hand on your chest. While blowing, you need to feel vibration in your chest. If you're not feeling vibration in your chest, it means you're not holding the mouthpiece tightly. So I will be showing the wrong maneuver. Blowing into the acapella by keeping your cheeks loose is an incorrect way. Now I will be showing it. So I am not feeling vibration here because I have not kept my mouth tightly sealed. You need to do this breaths for 8 to 10 times, followed by breathing control 4 to 5 times. Then you need to do 2 to 3 times of huff coughing and clear the secretions. Thank you.
I'm Shinsi. I'm working as I'm working as CF dietitian in CMC Vellore. Today my session will brief you about nutrition in cystic fibrosis and pancreatic enzyme replacement therapy. The first session starts with the nutritional aspects. Children with CF have increased energy requirements to compensate for the energy losses due to malabsorption, for the increased work of breathing, and to fight infections. It has been proved that maintenance of normal BMI is associated with good lung function in children with CF. Hence, to compensate for the energy losses and for the normal growth, it is important that we supply energy through high-calorie diets. Next, moving on to the standards of care laid down by the Cystic Fibrosis Foundation. Majority of the CF children have pancreatic insufficiency, which leads to malabsorption of fat and fat-soluble vitamins. Hence, we provide them with pancreatic enzymes, and these are calculated as lipase units per kg body weight per meal. The next one is adding calories. So, since their energy expenditure is high, we have to provide them with 130 to 150% more than their RDA for age. The next one is the CF specific vitamins. Since there is malabsorption of fat soluble vitamins, we have to supplement them with vitamin A, D, E, and K. Apart from these three, you have to keep a track of their growth, as a CF child is expected to maintain a BMI at the 50th percentile. Moving on to the nutritional management. As we have said earlier, that these enzymes have to be provided. So these enzymes are dosed based on their weight gain, the amount of food consumed, the fat present in the food, and their bowel movement. So approximately for every 5 gram of fat, we can administer 1/10,000 unit of pancreatic enzyme. A liberty enjoyed by the CF child would be unrestricted diet. Hence, we have to provide them with a high fat, high protein, and high calorie diet. And 40% of the total calorie intake can be contributed by the fat. The next are the CF specific vitamins A, D, E, and K. Next will be the salt. So CF children tend to lose excessive salt through their sweat. Hence, we have to provide them salt through their food intake. Then is the fiber. So adequate fiber is necessary, as a CF child is expected to pass 2 to 3 stools per day. Plenty of fluids have to be included in their diet as it prevents constipation and dehydration in children with CF. In providing optimum nutrition for children with CF, we might face many challenges. For example, loss of appetite due to some illness or lack of taste or smell sensations due to nasal polyps or sinusitis. In such cases, we might opt for NG tube feed to optimize food intake temporarily. In other cases, we can also choose feeding gastrostomy as an alternate option. Coming on to the next topic, the pancreatic enzyme replacement therapy called the PERT. So pancreatic enzymes are digestive enzymes in the form of capsules. So these contain the lipase, protease and amylase. And these originate from the combination of porcine, lipase, amylase and protease. So as you can see here, these contains granules. So these granules are enterically coated, and this enteric coating helps act as a polymer barrier by preventing its disintegration in the gastric environment and further facilitating a better absorption of nutrients in the duodenum. In India, there are two dosage strengths available. One is the 10,000 IU and the other one is the 25,000 international units. In other countries, we can also find dosages like 3,000 IU, 6,000 IU, 12,000 IU, etc. So next, coming on to the major part, which is the dosage. So as I said, enzymes are dosed based on the weight of the patient and the fat present in the food. Hence, dosage for each and every child is tailor-made. And these are calculated based on lipase units per kg body weight per meal. The guidelines by Cystic Fibrosis Foundation suggest the following. For infants, it is 2,000 to 4,000 lipase units for every 120 ml of breast milk or formula feed. And for older children and adults, it is 500 to 2,500 lipase units per kg body weight per meal, and half of it, which is 250 to 1,250 lipase units per kg body weight per snack. So a CF child is expected to consume 3 major meals and 2 to 3 snacks per day. Gradually, the dosage would increase for a CF child as the weight and nutrition improves. So coming on to the vital part of the PERT, which is the administration. So there are certain do's and don'ts which we need to follow in order to prevent faulty method of administration. So I'm going to start with the do's. So the first one is, it is always ideal to consult a CF dietitian to know the right dosage of PERT. The second is, it has to be administered along with the meals. So it can be either at the beginning of the meal or halfway through the meal or by the end of the meal. For older children, it is easy to follow this routine of before meal or after meal, as you have an assurance that they would complete the meal. For younger children, since you can't assure that they will complete the meal, you can always give the enzymes halfway through the meal. So for the amount of food consumed, there would be some amount of enzyme given. So coming on to the infants. So infants require very smaller dosage of enzymes. Hence, it is always suggested that you open this capsule, and you can approximately divide the granules in equal parts. And these equal parts, you can pack it in pouches and keep so that you can use it for the next feeds when you feed the child. So you can give one part of the granules with an acidic medium. Take a part of the granule and give it with acidic medium. So this acidic medium can be something little stickier, so that the granules are not lost and it remains intact to it. So we can suggest acidic mediums like jam, jelly, yogurt, applesauce, etc. So this can be easy for swallowing also in infants. The third would be, it has to be provided with every meal containing fat. So every meal, every snack and every beverage of a CF child should consist some amount of fat so that it will be easy to give the pancreatic enzymes. So a child might miss out a dose of pancreatic enzyme. Hence, there is no need to panic. You can compensate these doses in other feeds where you can give a fat-rich food and you can also increase the dosage. Coming on to the don'ts. So there are certain don'ts which you have to follow. So do not crush or chew the capsule as it gets deactivated. Then do not keep it in your mouth for a longer period of time as it might cause mouth irritation or mouth ulcer. Then do not mix it with foods that are hot in temperature as high temperature deactivates the enzymes. And allowing the granules or capsule to sit for a longer period of time in food is not advisable as a prolonged moisture can also deactivate it. Also, the granules might get lost and wasted when mixing with whole foods. You need not give crayon with low fat foods. So low fat foods would be like your fruits, vegetables, aerated drinks, candies, etc. You need not give pancreatic enzymes with this. So how do you think you can get to know if your pancreatic enzyme dosage is right? So adequate weight and non-foul smelling, non-greasy stool 2 to 3 times per day is an indicator of your right dosage of PERT. These are some of the different enzyme preparations available in the Indian market.
Yeah. Good evening. So I hope it was beneficial, the videos which we had shown. Now I just want to address another aspect of CF care, that is about infection control. So Dr. Grace Paul talked to us about how they manage this problem of infection, the spread of microorganisms, pathogens from one CF patient to another by following, avoiding droplet spread and contamination of the area where they are using, similar to what we are doing now for COVID-19 pandemic. So most of the Western or developed countries, they have very strict protocol on how to do these things. They distance the patients, and between patients, they clean the room and the places they used. And staff always wear a gown, mask, gloves when they go in to see the patient. So these practices are ideal, but sometimes the logistics of applying this may not be, it may not be possible to apply to that extent in our country with the crowding and the number of patients we have to see and the time allotted per patient. So it's still, it is important for us to understand the principle behind it and ensure as much as possible that we physically distance one patient from the other. So I'm actually talking before this pandemic, but now everybody is wearing masks, but I'm talking about just regular times. CF patients, children are advised to wear a mask as soon as they enter a hospital setting where they meet another CF child. And so one of the things that we do in our hospital is, because many patients will be wearing masks. So when in our outpatient, we usually give appointment in such a way that we don't see consecutive patients, cystic fibrosis patients. So, one may have an appointment at 8 o'clock and the other one will come around 10 or 12. So, there is a little bit of a distance between patients. But still, when they go to the X-ray department or to the lab, there is a possibility, or in the cafeteria, they may mix or interact with each other. So we have a simple solution to this. This mask you're seeing in the background, this is a special mask we made for them. And each of them is given 2 sets of masks. So the advice is when you come to this hospital, wear this mask and come. So it's like a secret code between the patients that if you see somebody else wearing this type of a mask, you know that it's a cystic fibrosis patient. So take the necessary precautions. The other point I want to make about, so what is possible or what is practical in our hospital or in India, we need to do. And we always ensure good hand washing techniques. And all our staff who are caring for cystic fibrosis patients, we all have got ourselves immunized with flu vaccine so that we don't spread infections to them. This is all before the pandemic. Now the situation has changed, of course. The other point I want to make was about the use of hypertonic saline. Sorry. So, we have hypertonic saline available as a 100 ml pack here. So when patients repeatedly take this, they take it home and they repeatedly aspirate from that packet, what happens is it can get contaminated with pathogens, especially things like fungus, pseudomonas, etc. As a result, that becomes kind of a threat to their, they can get infections from the medicine what they are using. So since the smaller packets are not available, what we did in our hospital is to make, our pharmacy handmade these packets of this pharmaceutical grade sodium chloride, and it is dispensed along with small vials of distilled water. So when it is mixed together, 150 milligram mixed with 5 ml gives you 3% saline. And if you put 2 packets in one, it becomes 6% saline. So this is what we have been following, but it is not it's not possible everywhere for the pharmacy to handle such volumes. So Grace and I have been talking to some pharmaceuticals to help us in this problem. And I'm glad to share this information, which I got from reliable sources, that one of the companies is planning to launch this product, small vials of 10 or 510 ml of hypertonic saline, 3% as well as 7% soon, maybe in the next couple of months. So that will solve a big problem for us of contamination. Now, just one note about the multidisciplinary CF so in India, we haven't reached the concept of CF center, a central center and the branches, etc. And also in India, medical care is not uniform everywhere. The accessibility, availability is very, very diverse. So similar standards may not be possible, but it is important to understand the principles and adhere to it as much as possible, following each of these aspects we discussed today. Now, it's very important to have a good collaboration with various team members if they are available. So usually the pulmonologist owns the patient, and they, most of the developed countries, what we have seen is they own the patient and they coordinate the services of other specialists. So here it could be pulmonologist or pediatrician or any doctor who has an interest in the condition and who will take ownership of the patient is good for our country. But also we must involve one doctor very close to the patient's house who will be able to address any kind of immediate problems they have. Because many times to reach this primary doctor or the pediatrician or pulmonologist, it may many hours of travel, and the emergencies can be managed by a doctor who again knows about the condition and the principles of treatment. So if you don't have different specialists like therapists, respiratory therapists, etc., we can have a nurse trained in many, a nurse who wears many hats, and she can take care of it. Dr. Cabra, has shown this very clearly in his clinic, and that is also possible. So in our setup, maybe the pediatrician and one nurse who is interested can take over the role of all these various members, and we still can provide all the care which any patient in the Western countries receive. Now, when you take specialist consultation, a word of caution that that specialists should have had some exposure or special training in cystic fibrosis, because it is a little different from other cases. So usually we consult gastroenterologists for many of the GI troubles, pediatric ENT, endocrinologists when they get into the time of CF related diabetes. We need the surgeon's help many times for sometimes bowel obstruction, distant intestinal obstruction, etc. Surgeons especially need to be experienced, because these patients may come many times with what it looks like abdominal distension and obstruction, and they don't need surgery for each one of those events. If you start doing surgeries, this child will have 10 surgeries in his lifetime. So the surgeon has to be experienced in CF, how CF behaves. And sometimes all it needs is just, relieving constipation with the medications, and surgery is not needed. And services of mental health professional, if available, will be really excellent for the family, the child, the adolescent, and sometimes the doctor also may need this. And adolescent medicine doctors are very good with some of the children who are reluctant to follow our advice because, that age it's difficult. And they also help us with transitioning them to adult care. So even if we don't have the ideal setup, we need to improvise with what we have. And if we know the principles, we can look around and find solution for that in our country. But we must work within the standards prescribed. We can't improvise to such an extent that we deviate too far from what is the correct way to do it. And working with other experts who have some experience will definitely help, because others have seen similar situations, and that will be very helpful. And in the international forum, there is a lot of interest about India. Many are willing to help us in education, capacity building, etc. And many of our friends or alumni from our medical colleges are working in this specialty itself. Many CF centers, I know Indian doctors are there as CF specialists. So they may be very much willing to help their alma mater, like Grace is helping us now. So that is very much possible. And we discussed about registry yesterday, which is very definitely needed, because we have to show the magnitude or the burden to know what it is, so that the necessary arrangements can be made from the government. And so that is important also to get ready for access to new drugs. And in the next few years, we need to catch up or fast track our development or our knowledge, the way we work, so that 50 years of progress which they achieved in the developed world, we should achieve in just 1 or 2 years, because it's possible. Knowledge is there. We can do the capacity building very easily. Just a quick word about the CF India project. As we said before, this is a collaboration between these hospitals supported by CF Foundation. The goal is to improve the standard of CF care in India through many educational sessions and help others in diagnosing CF. So, and training of allied health professionals, etc. So we started helping with sweat testing facility in different cities. Going there and doing sweat testing camps. We can provide guidance if anybody wants to set up this facility in their own hospital. And once this pandemic is over, we hope to train the technicians who are interested, or if hospitals are interested, we can train the techs to get this done properly. So this is our logo for the CF India project. In case you need to contact us, that's our contact information. The team which you saw now, we are willing to help if doctors want to refer. I mean, we don't encourage patients to directly contact, because we really want to know the background of the patient, and it should be through the doctor as a service. If you would like to get some specialized care given to your patient, you can contact us. We will be glad to help in a way which is possible. We'll have to do that through our telehealth services in our hospital. And we hope we can help set up many centers which give the good CF care in India. Thank you.
Thank you, madam, for that wonderful session. And there are a couple of questions quickly before we go to Dr. Karen. I think you need to wait for a couple of minutes before madam would answer a couple of questions from the audience. Is there any ceiling dose for pancreatic enzyme replacement therapy?
Shall I answer that?
Yeah, please.
So the reason behind that question may be because of the complication which is mentioned in textbook about fibrosing colonopathy with very high doses of pancreatic enzymes. This was an entity which used to happen in the earlier days of using PERT. Now we know what the correct dosage is, and with the amount of pancreatic enzymes we use, there is absolutely no risk of reaching there. You saw Shinsi's slides on the doses. if you actually look at the doses our children are taking, it is minuscule. We are not reaching anywhere near the suggested doses. So definitely there is no risk of our children developing that. And the limit, if you ask me, it is 10,000 units per kg per day. So for a 10 kg child, should not be taking, more than 10 capsules. A 20 kg, 1 capsule is 10,000 hour dosage. So that's why I'm saying like that. A 20 kg child should not be taking more than 20 capsules. Just a simple way to remember that. And as all of us know that our children are not going anywhere there. So there's no worries there.
Do you want to give pantoprazole before that?
So we can't be administering pantoprazole chronically for patients. Maybe for a short time we may use to decrease the, to keep it more alkaline medium to facilitate this. For some time, if it is not working for a short time, we may use pantoprazole. But we can't administer pantoprazole chronically to patients unless there is a specific reason for that.
Yeah. Thank you very much, madam. That will take us to a small break. You bear with me and with myself personally. Many a times we listen to the demonstrations, we say, wow, superb. I saw all those remarks. Can I have couple of participants? Please raise your hands now. Can you demonstrate what has been demonstrated? We will have some fun. Now, who will raise the hands? I wanted to see if there, Dr. Radhakrishna, sir, I would allow you to come in. Sir, I would be asking a specific question. Dr. Radhakrishna, sir, unmute yourself, put the video on.
Good evening, one and all.
Sir, there is a specific question. I am introducing you. You are one of the leading practitioner in Vizag, and every one of us know you are very patient friendly, one of the busiest hospital. But now the question is very specific to you. Sir, please demonstrate huff coughing. We will have some fun. Huff coughing.
Hari?
Is that okay? One more time.
I am seeing Dr. Grace, Dr. Karen, and Dr. Sneha Varki. Will you pass him in MD or no?
No. Give me one more chance.
Yeah, please. Fine?
Not
Okay.
bad.
Past.
Pass.
Mr. Hari says past.
I want all the panel, all the audience, please clap for Dr. Radhakrishna. Clap, CLAP. Wonderful. Sir, just stay on. I want to invite the next person. One more for 3 maneuvers. Anybody else, please raise your hands. Anybody else? Now they're not raising the hand. They're worried. Simple question, Dr. Shyam. Okay, good. Come in. Dr. Shyam, unmute yourself, video on. This would make the audience participation. Dr. Grace, Dr. Karen, and Dr. Sneha, madam, this is what we do. They need to just get the proper messages. They should be in. Is Dr. Shyam in? No? No?
Subramania, shall I do that breathing? I can do it.
Yes, sir. Then very good. I want you to do that pursue lip breathing. Yeah. Can you do that?
Yeah.
Sir, just turn sideways because the lips can be seen. Okay. Yeah, now turn. Yes, that's the position. Correct. Okay. Now please do. Shyam, hold on for a while.
Yes, sir.
Again, I'll repeat.
Correct or not?
You repeat, sir. Now you are repeater. Fantastic. Very good.
2 and 4 seconds. 2 and 4 seconds.
Fantastic. Everybody clap for sir. Wonderful. Now, I do have one more person just joins. Dr. Shyam. Dr. Shyam, can you introduce yourself? Unmute, introduce yourself.
Yes, sir. I'm Dr. Shyam Chandrasekhar. I'm a postgraduate 3rd year in AIIMS Bhubaneswar.
Fantastic, yeah. Wonderful. A postgraduate coming forward. I mean, for a teachers like us, it is double clap. Dr. Shyam, this is the question for you. Can you show us what is breathing control? Now, for this, you put your hands on your tummy and we have to really see. You should take your mobile a little far. Yeah. Some more. and turn a little side so that we can see your tummy. I think you have 6 packs. Yeah, wonderful. Now, can you do that exercise for all of us? And this would be the last. Turn to one side. Rashmi Das, congratulations for having a wonderful student. And he's saying he's our student. See, your teacher is proud of you. Now you are already past MD. Don't worry. Right? So thank you very much. So this was just a break for the participants to see that whether they would assimilate. Every time we conduct Respinars, we see that the panel, there won't be one way and everybody parts. Radhakrishna sir, and please, if you are staying on, please mute yourself. And wonderful to have you. While I think, Sneha madam, can we go to the next session with your permission? You
Yes,
have
please.
anything
Yes,
to add?
please. No. Please go ahead.
Yeah, fine. Thank you very much. Now we have much awaited session from Dr. Karen McCoy. She's from US, and not just that, she has spared her enough time for all of us. And you know what? She is going to demonstrate, show us her presentation on CFTR modulators, and thanks to Nationwide Children's Hospital from Ohio. Madam, we will invite you on behalf of respiratory chapter as well as from the team CF over here and all the panelists. We are eager to listen to you and you can share your presentation. Over to you, Dr. Karen. Welcome. I think it's morning there. You can start with good evening for all of us.
Good evening, everyone. I have a very low IQ in presentations like this, so I was needing some help. I'm going to get started here in just a minute, but I would like to tell you that I am extraordinarily glad and excited to be able to share the experience that we've had with the launching of all of these transformative medications that we all are embracing with great excitement. So you've had very, very excellent presentations along the lines of background for this. And that having been said, I am going to jump right in. Please just tell me if you're seeing everything on a slide saying median predicted survival. Okay, now what I'll show you here is when I entered the world of cystic fibrosis. Of course, I was only 3 years old at that time. And it was a long uphill battle for me. But of course, you know that among Caucasians, this is among the most common lethal inherited diseases in the world. We claim to have about 30,000 individuals with cystic fibrosis in the US, and worldwide. We know it's much more than 80,000 that are out there because there are so many places that have difficulty in making a diagnosis.
Madam, Dr.
Yes?
Karen, can you please adjust the camera for us? Your camera, laptop camera.
Oh, I'm so sorry.
Yeah, fine.
In order to see my advances, I had to do that.
Thank you.
Okay, so, as you know, the incidence is variable in other non-Caucasian ethnic groups, but I can tell you from a long history of scholars that participated in the program that Dr. Varkey did, it's everywhere in the world and in all ethnic groups, and everybody's aware of the clinical manifestations. So I'm going to take you over to this side and basically say this arrow accounts for the first time we participated in a clinical trial for cystic fibrosis. It's my understanding that at the time that was the second ever. And then up here, we start the beginning of the US Therapeutic Development Network, which started out with less than 10 centers. And then, a lot of us joined within the next few years to the point where it's nearly 100 centers Next were things like tobramycin solution, azithromycin, quality improvement, just how you do things makes a difference. And this is the life expectancy that was as of 2016 and the present. We know that it's increasing every year at this point. And all of this down here was hard-won difficulty that involved all of the therapies that you've just heard about from Dr. Paul. Then we get on into other things. We know there's lots of organs affected in CF, and Dr. Paul had already covered this. So I'm just going to interest you a little bit in that we're not sure that there isn't some role for CFTR in the brain. And of course, everyone is very familiar with the look of these totally opacified sinuses, as well as the horrible bronchiectasis, mucus plugging, and so forth that we see in the usual lung. And it's already been mentioned that the FEV1 is higher for every age and every severity level based on having the best possible BMI. That's all the prep you're going to get. Now we're going to CFTR, and you've seen some beautiful slides from Dr. Paul today. This is a normally functioning CFTR cartoon. There's a bunch of them, and in most cases, the defects that cause cystic fibrosis render all these chlorides, the water and the sodium that goes with them, stuck inside the cell and not appear in the mucus where it can benefit the patient. And that's for every organ that is affected in cystic fibrosis. So there are about 3 main ways that CFTR fails. One is that the CFTR channel does not open. It's there, but it doesn't open. And in about 5 to 8% of cystic fibrosis in the European, US, Australian areas, this is represented by G551D. And there are others, and we'll kind of get to that, but these are relatively easy to fix, as you all know. The next kind of problem is where the abnormal CFTR is destroyed by intracellular mechanisms, and very few of the channels ever make it to the cell surface, and they are unable to open even if they did. And this is true for people who have 1 over here or 2 copies of the F508 gene. And in the population that we deal with, this represents somewhere approaching 90% of CF, and it's much harder to fix, as you know. And then finally, there is the defect where no CFTR protein is made, this nonsense or X mutations as they're called. And this is very difficult. It's impossible to fix a protein that's not there. And this form is present in somewhere close to 10% of the Caucasian population that we're aware of. You've seen this before, and I'm not going to go into any details here, just to say that one of the advantages of having this view is that when you have something that has like G551D, a defective channel regulation, then these other classes sometimes mimic those primary defects that we target, and the extension can be made that they may be improved by 1 or more of the modulators that are existing just by doing some N of 1 types of testing. So let's march through the, let's march through the sort of groundbreaking progression of this. So this one is the original CFTR potentiator in people who have at least 1 copy of G551D. And as you can see, there was a significant change in the average percent predicted of FEV1, not seen in the placebo patients, and the difference was statistically meaningful. The sweat chloride example, this was a drop of nearly 50 microliters per millimoles per liter, and the placebo did not have that. Again, very significant. And then an instrument that you may be familiar with, our cystic fibrosis quality of life, respiratory and revised, where there is a minimally clinically important difference of +4. And as you can see, the ivacaftor group achieved that. The placebo did not, and that was also significant. The adverse events were largely related to things that happen to people who have CF, not more predominant in the treated versus the placebo group. And there really are, other than monitoring for liver functions periodically, there are not a lot of safety controls with this one. Again, it reaches a fairly small group of the total CF population in our demographic. Next was the combination of lumacaftor and ivacaftor, and this was for F508 homozygotes. It was proved previously in early phase studies not to have benefits for heterozygote F508s. These are the conditions. You can notice here that there are a lot of patients included in this trial. The duration was 24 weeks, and then it was divided into 2 studies that were done that basically utilized this one dose of ivacaftor, this other dose of ivacaftor in traffic and transport. And unlike ivacaftor alone for the G551D in these F508 homozygous patients, there was kind of a not so meaningful difference in either dosage group, but because there's so many people in the trial, it did come out as statistically significant, but we do not think that it is clinically significant at all. And then the CFQR failed to meet the minimally important difference here. Even so, this was statistically significant. Of note, there were a good number of complaints of acute dyspnea and chest tightness among people at the lower end of the pulmonary function. It did seem to present as fewer pulmonary exacerbations, but nothing was really very striking, and we really knew that we were not dealing with a highly effective CFTR modulator in this case. Then again, for the same homozygous population, an alternate controller was introduced, and the potentiator ivacaftor was kept. And in this group, there were 248 in the treated group and a similar number in the placebo group. And this did have a signal that was more impressive. It was statistically significant. The sweat chloride drop was only just under 10 millimoles per liter, and there was no real change here. CFQR did meet the clinically significant, and one of the things that many of us who participated in these trials noticed was that the treated patients did gain a bit more weight overall, but it was certainly not significant. There was no chest tightness in this combination, and this of course became the compound that's now known as Symdeko, and there was also no significant safety concerns. Now we're going to talk about Trikafta, or the combination of elexacaftor plus tezacaftor plus ivacaftor, which was the follow-on for this. And let me just say that this was 12 and above, same limits on FEV1 to be included. There were only 107 total patients that were recruited for this. And initially, both groups started with 4 weeks of tezacaftor, ivacaftor, or Symdeko as a run-in. So they started from the same place. And then they were randomly assigned to add elexacaftor or to add a placebo to the Symdeko, and then they continued on. Notice the very small number of people for a worldwide trial here. And in addition to the run-in improvements of about 4 FEV1 percent predicted, there was another 10 compared to no difference. And this was highly significant in spite of very low numbers. The sweat chloride drops were quite satisfying, not seen in the group that did not have the elexacaftor, and also very statistically significant. CFQR sort of knocked it out of the park. While there was no difference in the placebo combination, there was almost a 17.5 difference in percent difference in, or item difference in the people who were on the triple combination, also highly significant. There were significant weight gains. There were significant improvements in BMI as well. So again, no AEs that did not generally fall into the group of, you know, if you have CF and you have a pulmonary exacerbation, that's pretty expected. If you have CF and you have a cough, that's pretty expected. And so those were the nature of most of the side effects that were seen, or the adverse events that were seen in this trial. And then simultaneously, sorry about that, simultaneously there was the trial that looked at, seems to want to go, that looked at people who were heterozygous, had, in other words, had one copy of Delta F508, also greater than or equal to 12 years old, same FEV1 limitations, and lasting for 24 weeks. The percents of increase in FEV1 were impressive, not seen in the group that did not have the lexicaptor, highly significant. The sweat chloride changes were similar to that seen in the homozygous group, although there was, I know, a bit more of a range, not seen in the placebo group, and highly significant. And then the CFQR were very, very identical almost to that seen with the homozygotes, not seen in the people who had no elexacaftor, and also highly significant. Side effects were common to CF, and there were no safety concerns associated with this trial. So here's how we stand right now. There, for ivacaftor, they've added a few that were like R117H and those others that have the more minor defects in gating types of activities. And this is approved down to 6 months of age in the US at this time. Lumacaftor, ivacaftor, or Cambi is now approved down to 2 years of age, and they're working on this group as well. The tezacaftor is back at 6 to 11 year olds and above 12. And right now, the triple combination, or Trikafta, is approved at 12, and the data are in for this age group. This group is being recruited and put through the process right now. And this again is what you would call a highly effective CFTR modulator, like ivacaftor was for the right genotype. But we're waiting very expectantly to be able to get this medication in the younger age groups, because there's even a possibility that we could see the rescue of the pancreas if we timed this right in this group of patients. So that's very exciting. Monitoring for the modulators is pretty consistent all across the several different modulators that I mentioned. We check liver function test at baseline every 3 months for the first year, and then after that annually. We have an EKG because these medications have drug interactions that can precipitate short QT and trigger arrhythmias that can be lethal. We have an eye exam in those under 18 years of age. There has never been a clinical human outcome of cataracts, but in some of the developing mice that were tried, there were cataracts, and so we're doing that to be extra cautious. And then there's a drug interaction evaluation that's standard, and that includes things that you are taking, things that you might have taken and could take again, or things that with age, such as oral contraceptives might come into the picture. Those are also included in that analysis. And then any other labs are done according to the standard of care for the population. So a really, really important question is, does it last? And we don't have a strictly obvious answer for that right now. But I can tell you that if in these two studies that looked at disease progression in people who were on ivacaftor and were carried out for 5 to 6 years compared to people who had no modulator, there were important changes that were seen that included a reduction in the colonization in this is the ivacaftor treated versus the no modulator person at the year 4 mark, and they're losing some pseudomonas, and this occurred in the registries in the US and in the UK. We also saw that, I'm sorry, I might have skipped a slide. Yes, this one. In both the US and the UK patient registries, the lung function increase and then in both groups was seen, and it's sustained out to this 5th year of following these patients. So we think that it's an enduring change. You don't become immune to it, or it doesn't get, to where you don't have the same treatment effect. We feel like, but obviously can't know yet, that this is going to be a difference. Here's another example of 144 weeks of follow-up with ivacaftor and G551D that showed that the benefits persisted and there weren't any safety concerns. But we feel like that this is going to be true of the triple combination or Trikafta as well, because of the size of the effect. There's also some, there's also some interest, our group here, and this is our Cure CF Columbus our research and development program, is very interested in the immune deficiencies that are part of cystic fibrosis. Things like the macrophages don't work very well, the neutrophils don't kill bacteria, and we even think that adaptive immunity is abnormal in these groups. And we're looking at whether we can show meaningful differences in cellular and adaptive immune changes that may facilitate actually not having to worry as much about the colonizations and infections, and the fact that we are running out of antibiotics and not very many new ones are being made. So that's something that's coming up in our studies, and we really would feel like that would be a wonderful thing to be able to say about the benefits of these drugs. But I think patients speak louder than doctors, and I'm going to share this case report of a homozygous F508 patient who was very far advanced. She had been a competitive horsewoman, but was now unable to ride because the jolting of the horse made her cough so badly that she couldn't stand it. And her mother had, this was unknown to me before we placed her on this medication on a compassionate use basis back in the summer of 2019. Her mother had been sleeping on the floor beside her bed to assist her with the severe choking attacks that she would have on the average about 5 times each night. So she started Trikafta in July of 2019, and because she had such low lung function and was actually, the next step up was to consider her for transplant. We brought her into the hospital to initiate the therapy, thinking, well, what if she has so much secretion clearance that she's choking on it? We want to be safe for her. Nothing like that happened. And she was discharged. And after this patient, we no longer brought people into the hospital to start them. We felt safe. We felt that we could do this in the clinic and watch them for a couple of hours, but that there was no, immediate danger to them. And this young lady came back to see us in about 2 weeks. Her mother had returned to her own bed because she wasn't coughing at night anymore. She had been on, sort of compassionate use pulmonary rehab, which meant that she would go in at intervals and get her SAT checked and her heart rate checked, but she didn't actually do any physical activity. So we were able to progress that very, very quickly. And she started really working out in earnest. And then at 6 months on the drug, she ran her first 5K race and has subsequently done a half marathon. So very, very important changes in the way these people function. And characteristically, this is a sputum production of one day of another of our patients who is a 52-year-old female who had very advanced disease, but was one of those people who was extremely adherent and did everything we asked her to do. And so she participated in drainage for several hours a day, and this was her usual output. And then we started her on medication, on Trikafta, in the early fall of 2019, and by about 3 months on drug, you can see that these are a whole day's worth of sputum production for her that really is dramatically decreased, and she's never again needed a sputum cup. She had to measure these in teaspoons. So I think that these are amazing medications. We do not know at this point, the long-term benefits, but it looks robust to us. It will absolutely transform cystic fibrosis. What we wish for is market competition, because these drugs are extraordinarily expensive, but they are extremely, extremely transformative to these patients, and we have used them pretty extensively. So what I'll say is cystic fibrosis from here on out, it will look different, and the difference will be very, very good. So shameless cry out to the people that some of you know here who participate in our research and our clinical operations, also some of my physician co-investigators, and we're just totally excited to have this collaboration between your country and your CF patients and ours. And so with that, I will say I have said all that I need to say, and if people have questions, I'd be happy to try and answer them.
Thank you, Dr. Karen. If you could stop sharing the screen.
I'm trying, and I will do it as soon as I can, but I might need my advanced helper again. So let me get that help, and then you can start with questions.
Yeah. It's okay. I think we should let her come, then we would clap for her. Madam, you should see the screen while all the audience, please clap for madam. You can type CLAP in the chat box.
Thank you very much, everyone.
Yeah, we can see many. We would come to the last part of the session today, that is question and answers. We will be going for the questions from the audience directly. We will allow you to come and speak, but we would frame some rules for you. You have to introduce yourself in one line or half line if possible. Please spare the time for the science, not for anything else. There is no need to tell this was a remarkable session, fantastic session, we congratulate everyone, and all these things are fine from all of you. Whatever you want, you type in the box. When you came directly, please stay on focus I will promote you one by one, but you should ask your questions and we will remove you from the faculty box only to allow the others in. Please don't feel offended. Is that okay for all of you? Then say yes.
Yes.
Yes, all of you, fine. Then Dr. Jagdish Chinappa wants to have a word, then I will go for question answer session.
Um, Thank you, Dr. Karen, for that excellent presentation on the CFTR modulators. I can only share a personal experience that I have a child who's 30 years old now, who has CF from the time we detected it at 2 months of age, and she went to the US for a transplant, and she's now on Trikafta, and they have taken her off the transplant list because she's doing so well. And in fact, very remarkably, she even got married recently, and she's doing exceedingly well. So I think these drugs are going to change the whole scenario of cystic fibrosis. As you mentioned, the cost is the major problem, but I think the company has been very good, and I think we should really congratulate a company like Vertex, which has taken the lead in this. Because I was reading about how they started getting into this CFTR modulators, and I think it was primarily because of a compassionate kind of attitude of the company. So I think it's a wonderful session that you have given us on the journey of these modulators. Thank you very much.
Thank you, Dr. Jagdish. That was a nice remarks from the president. No, we would allow every one of you. See, we will not make you disappointed. Dr. Padmanabh Maya, can you unmute yourself and ask your question? Unmute, videos on, and ask your question. Anybody wants to come in, please raise your hands. Sir
Hello.
Maya, sir,
Yes.
all the panelists over here, Professor Dr. Maya has been a teacher of teachers for all of us in Bangalore. And Maya, sir, over to you.
Hello.
Glad
This is
to
a
meet you.
question. This is a question to Dr. Varki. What you presented yesterday, the 1983 3 cases were reported by me, and they're all manifesting as edema, anemia, and hyperproteinemia as a symptom complex. At that time, only 52 cases were reported in the world literature. And now you are also seeing a similar type of cases. I'm just wondering, because at that time, only 6 cases from Chandigarh by Dr. Saroj Mehta and 1 from All India Institute. That's all the cases. Now you are seeing same presentations only in and around Vellore, and not many cases in the world literature. Why is it so? Is it any genetic predisposition in and around Vellore?
Thank you for that question, sir. It's really nice to see you. You are a legend. Happy to see you actually online. Now, I can't say a definite answer for that. Sometimes it may be related to the rate of picking up. But I know many of my colleagues from different parts of India, yesterday, many of them messaged me saying that they also have been seeing these patients and they have probably been ignoring and not realizing it is CF, and patients have died. So I don't think it is a problem of being in a certain geographical area. I think it's throughout India, at least in different parts of India at least, and maybe it is not picked up. And we are doing genetic studies, and in a few months we may have some answers for that, whether there is any particular mutation which is predisposing to that. Delta F508S, and one more mutation I know in some of the patients who we lost, we found that frequently happening. So that the severe mutations is, the severe phenotype is.
Thank you, Dr. Vachi. I think you are doing a commendable job. And we had 3 more cases which are not published in the same time. Within a matter of about 5-6 months, all of them we got autopsy done. The first reports from CMC at that time. I think you must do something for that to see why that particular type of presentations are common in and around Vellore. Thank you very much.
Sir, thank you, sir. I couldn't recognize you on the name. It was written your full name. So you are popularly known to us as Dr. P.P. Maya. So I could not recognize you, sir. My apologies. And it was nice to see you and your blessings for all of us. Thank you very much, sir. Anybody, any other participants, please raise your hands if you want to come in, please. If there are any questions, any questions?
Subramania, can I ask a question?
Please go ahead, sir. Radhakrishna, sir, please go ahead.
Sir, sweat chloride facility is not available in most places. Genetic test has its own problem in the sense they pick up only some mutations. Then what is the next relative silver standard, if not a gold standard, for cystic fibrosis? With genetic tests capturing only 30-40% of the mutations and sweat chloride not possible even in a place like Vizag. Madam, please tell us what could be a silver standard at least?
So,
Dr. Sneha, madam, unmute yourself. Yeah.
Dr. Kabra, would you answer that question? I think you are the best person to answer that question. Otherwise, I can
Kabra,
answer.
sir.
Okay, Dr. Radhakrishnan, we had discussed this earlier also, and yesterday I showed you that one is that if sweat chloride is not available, you can just see few clinical and some basic laboratory tests. So one is that you look for, you suspect a child to be CF if there is a respiratory infections. Along with that, there is a malabsorption. You do a stool test for fat globules more than 10 per high power field. If there is a hypochloremic, hyponatremic, metabolic alkalosis, sodium, potassium, and ABG, and you do a sputum or a cup swab or sputum, induced sputum for some organism if there is a pseudomonas. If two of these are there, you are reasonably sure that it may be CF, but give a label only after documenting that there is a raised sweat chloride. Second thing is, as I told yesterday, that one of our patients' mother sent a photograph of her child that after giving bath, there was a wrinkling on the hand. And then we had to explain her that what may be the cause. And when we were reviewing the literature, we found that in 1973 in Lancet, there was a letter that yes, in 3 minutes, if there is a wrinkling, then it is likely to be a CF. So we did a study here and the sensitivity was around 82%. But specificity was 58%. So it can act as it can be used as a screening test that take the child's hand, clean it, put it in the water, see after 3 minutes, provided that there is a background of a clinical phenotype. So these are the various things which may be useful. We are still struggling for making a diagnosis, though Karen and Grace, they are looking for the cure of CF patients. And someone had asked the question regarding what is the cost of modulator in India. It's not available. You can import it. 2 of my patients are getting it. Orkambi will cost around 10 lakh rupees a month. That may be around $8,000 a month. That Syndico will cost around 15 lakh rupees a month, $13,000. And for Trikafta, it would be around $65,000 per month. Per month. This is a per month. Okay. So we are still struggling and we have to have our own protocol. We cannot follow this thing because I tell my students that when I was talking of the evidence-based treatment, then I took the CF Foundation's evidence that you give Trikafta, you give inhaled DNAs and other thing. Then the father of child told me that, sir, the child may survive, but my family will die because they have to spend around 1 lakh rupees a month. Okay, thank you very much.
Kabra, sir, in a continuation of the same question, is lung transplantation cheaper than the modulators?
Lung transplant, as Grace has already said, it is not very encouraging in cystic fibrosis. Even in US, the 5-year survival is 50%. And they are exposed to multiple infections because of the immunosuppressants. So that is not the answer. Answer is probably modulators.
Okay. Thank you, sir. Dr.
May I
Karen,
come in for 1 minute? May
Madam,
I come in
Dr.
for 1
Karen
minute?
and then you, because she has asked to make a comment. Dr. Karen, please.
I think that it is also worth mentioning, and I didn't say this before, but in the course of starting about 230 patients on this drug since it was approved by the FDA, in addition to about 20 who got compassionate use prior to that, we have noticed that even among the sickest of patients, including one that matched one of Dr. Paul's very bad looking lung CTs earlier in this program, there has been such a dramatic response that we are very carefully weaning other therapies and looking for clinical response to that. We may get some price breaks that way, along with the fact that we have almost never had to admit one of these patients again unless they're grossly non-adherent. And so hospital admissions, as well as concomitant therapies that have been the mainstay of treatment, will probably be replaced by modulators as well.
Thank you, Dr. Karan. Dr. Sneha, madam.
So about the diagnosis, Dr. Radhakrishnan was asking, I know from Vizag and coastal Andhra Pradesh, there are very many patients, many undiagnosed, some are diagnosed. So if you have difficulty in diagnosing, there are, you can send them to a place where they can test it because it's worth it. The reason is, now we are doing COVID testing. The result of it tells you you are positive today or not. It doesn't tell you about tomorrow. But much cheaper test is sweat chloride test. You go get the test done. It's a life-changing diagnosis. You can do something about at least the malnutrition, pancreatic enzymes part. You can start treating. So it's just a matter of thinking. It is less costlier than a CT scan. It's less costlier than an MRI. And in regions where there are plenty of patients, which we know there are, like Vizag, it is really worthwhile to establish at least one center which will do reliably the test. And then you have the answer to that problem. And if you don't have, in areas where you can't have access, there are Jharkhand and many places where they may not be able to do that. So what we used to do initially was who we could confirm, we said confirm the cystic fibrosis. The other group, equal number of patients were in that group called clinical cystic fibrosis, because the sweat chloride, either we couldn't do it for some reason or the level was not, marking the diagnostic range. So we treated them exactly the same because none of this treatment is going to harm them. If they have bronchiectasis, pseudomonas, treat them with all these steps. They need all the steps. Nothing will harm them. So keep treating till you have a chance to diagnose. It will come maybe 1 year later, 2 years later, you will get the chance to make that diagnosis. So don't delay treatment till you can diagnose. Use Dr. Kabra's suggestions of clinical diagnosis and start treatment without wasting a single day. That is the, the message I would want to, spread.
Thank you, madam. I think I will take the questions from Dr. Ritika. Dr. Ritika, unmute yourself and then ask your question. Radhakrishna sir will come back to you.
Yeah.
Hello. I have actually two questions to ask. One is that
introduce yourself, madam, please.
Okay,
so that
sorry,
we'll know,
I am.
They will know what to answer.
Yeah, sorry. I'm Dr. Ritika. I'm a pediatric pulmonologist practicing in New Delhi.
Okay.
And I have two questions to ask. One is that, do we have any objective tests that we can do to find out whether our dose of PERT is adequate or not? Because we are relying on patient's history and on subjective symptoms rather than an objective test. That is one thing. Can we do any test in these patients? And second question is for Kabra sir. Actually, sir, I'd read your paper on aquagenic wrinkling of fingers and toes, where you suggested we can use it as a screening test. So my question is that if we get a patient with history of aquagenic wrinkling of toes, and it's a significant history, but that patient doesn't have any other symptom or history suggestive of CF, is it worthwhile to subject that patient to a sweat chloride test just for screening? I'd asked this question to Dr. Sneha yesterday also, but I would like to hear your take on this because I've read your paper on this particular topic.
Dr. Kabra sir, can you respond?
Yeah. Dr. Ritika, you are aware
Yes,
that the sensitivity is 82%, but specificity is just 58%. So it
Yes,
may
sir.
happen in multiple other conditions also. And that's why I saw a doctor from Patna last week only. He had a increased wrinkling, and that's why he thought that he may be having a CF, though he did not have any other clinical features. Though we did a sweat test, and then we reassured him that you do not have a CF. So same thing is someone from Hyderabad. He called me that I read your paper, and then I get very significant aquagenic wrinkling at the age of 28 years, but I do not have anything else. So I suggested that if you have other clinical phenotype, go for a sweat test. But it is only for a screening test. So it cannot be a diagnostic test. It is very clear.
Yes.
And regarding the Grace, and they may be able to tell you if they have any other test. Say 85% of the CF may have a pancreatic insufficiency. If you are in doubt, then you can do a fecal elastase, and you can say that yes, it is a pancreatic insufficient. But otherwise, you have to go by the stool examination, that whether there is a significant this thing. So generally we in our clinic, we ask whether stools are large, bulky, foul smelling, whether they float in the commode, and then we increase or decrease depending on these findings, increase the dosage of creon. But I am not aware whether there is any, because earlier we were doing a 72 hours fecal fat estimation, but that was only in the beginning itself to document whether there is a pancreatic insufficiency.
So while on therapy, it doesn't. It has no use. The fecal elastase, if we do
Fecal
while on
elastase
therapy
will
to
not
find
be
out.
affected by your creon. So
Creon,
you can
yeah.
do it, but it will only say that whether you have your own pancreas functioning. It will
Okay.
not be that whether your
Affected by the
pancreatic doses are sufficient.
enzyme.
But Grace and Karen may tell more. They may be having a more experience.
Thank you, sir.
To go clinical based on clinical, anthropometrics. So that's the main thing that we monitor. And then, there's some report of compliance, and we can also counter check with pharmacy whether the patient's using it or not. There are
Okay.
some containers with counters, but we really don't repeat pancreatic stool elastase because, as he mentioned,
Yeah.
the basic problem is still there. So the external creon usage is big. We do it more clinical based.
Dr. Grace
So
Paul and Dr.
occasionally
Kabra,
what
she is an
happens is,
ophthalmologist. She would take up a study to find out if there is an objective assessment. So we would welcome you to
occasionally
take
what
up
happens is, if there is an increased doses, then there will be a perianal redness. So if generally you will not exceed 10,000 inclination units per kilo of lipase per day, but if even with the smaller doses there is a perianal redness, then think of that it may be higher, and there is a scope of decreasing the doses.
Okay.
Can I request all the panelists to
Thank you.
come on video so that, Sir Kabra Sir, Madhulika Madam, Dr. Jagdish Prasad Goyal, everybody. So I will take a snap. This will go a long way in the memory of all of us. And I will post it in the group for all of you. One smile, please. Yeah. And anyway, I'll share this with you. But anybody else wants to ask any question, please, other than those who have asked. Any questions? If there are no questions, then I would, Radhakrishna sir, you have still questions.
Yeah.
Yeah.
Madam, we were so inspired by your involvement in cystic fibrosis. On my part, I'll start a sweat chloride facility in Visakhapatnam in the coming 6 months. After all, it is a small amount. We waste huge amounts of money for unnecessary things. And getting inspired from your activity in cystic fibrosis, I plan to start a sweat chloride facility at Vizag shortly.
Thank you,
That will be
sir.
very good. Yes.
And Dr. Radhakrishna is the president of EAP Respiratory Chapter also. So he's going to invite all of you for a next conference in EAP Respicon. Sir,
Yes.
one line from you, invite everybody.
Yes.
Now, before we would proceed further, we will have one word from each one of the faculties. We will start from Madam yourself, Dr. Sneha Madam. One line and a message for all our viewers.
I think I have spoken enough now. I just want to express thank you to the respiratory chapter, National Respiratory Chapter, for this allowing this, to coordinate our activities like this. And thank you for all the participants for joining. So I think the messages from different talks has been clear. I hope we will really make the diagnosis early and really work towards best outcome for our patients.
Thank you, madam. Dr. Grace Paul, can you unmute and just give one message from you to the viewers, and you have read them now by the way they have asked questions.
So I think being in a role for collaboration, this is something, we are now doing one hospital to one hospital. That's something that can be expanded. And I am aware that the CF Foundation is very interested in global CF. Right now, they have heard about our, like last week, I presented about our experience at CMC and in India. And they have already established many things like this in other South American countries and Middle Eastern countries. They are interested in India. So, this is a great time to show what we have and show our infrastructure and how we can expand early diagnosis and treatment. So this is a good time for India in terms of this. So,
thank you, madam.
Thank you.
I request the audience not to go away because there is an interesting session following this. Dr. Karen, would you like to make any final comments?
Yes, I would. I would say think positively about the future for cystic fibrosis. It would be a dream to have some of these medications become available in your country. And the sweat test issue, it's not just a diagnostic tool. It's a biomarker for these things working. You can tell if people are taking them properly. So go on.
Thank you, madam. Dr. Madhulika, madam. Dr. Madhulika Kabra, madam.
Good evening, everybody. Thank you very much for involving me in this very interesting seminar. And I was really overwhelmed to see the response of audience and their participation in this very targeted area, and also their interest in genetics of cystic fibrosis. The kind of questions I received yesterday, they were really interesting. What I would just like to say here is that though not mandatory, I think molecular testing for cystic fibrosis would be important in our country for confirmation in certain situations. But if the family is planning another child, I think it's extremely important to get a molecular testing done, because a definitive prenatal test can only be done once you have the mutation proven cases, because otherwise it will not be possible to provide prenatal testing. There are indirect methods like linkage and all, which we do not prefer. So in this situation, I think you should ask the family to get it done. And as I said, still Delta 508 remains the commonest mutation here, though the frequency is less. That can be tested easily at many places. And if not, then we can go for extended testing. Thank you very much again.
Thank you, madam. Dr. Jagdish Prasad Goyal, unmute yourself.
Okay. Good evening. Thank you, sir, for involving me in this seminar. I would like to give message. If any child who has presented to you with failure to thrive, persistent or recurrent pneumonia, large or bulky stool, think of CF and refer the child to appropriate center for proper diagnosis. So again, think of CF or smell CF, then you might be able to diagnose CF. This will be my message to all.
Thank you. Thank you, Dr. Jagdish. Kabra, sir. Dr. Kabra, sir.
Okay, so I would say that we have to break the myth that CF doesn't occur in India. It does occur, and you can see that all people sitting over here, Eileen, Jagdish, Dr. Sneha, PGI Chandigarh, these Jagdish in AIMS, all of us are seeing CF patients. And our aim is to strengthen the services, specifically diagnostic. And that's why the multi-site project is ongoing. That's from SKIMS to Vellore. We have 4 sites where we are collecting the data, and Jagdish might have shared the CF registry data, which we collected over a period of 1 year, 94 patients. And now the next step would be to go enter all the patients who are in our follow-up. Say at AIMS, it may be around 700 children. At Vellore, it may be more than 100. So we'll enter it, and then so that our CF registry will improve. And third step would be to include all the patients being seen by other practicing pediatricians, so that we can say that, yes, what is the characteristic of CF in India. Thank you very much.
Thank you, sir. Now, Dr. Eileen, any final word from you?
Thank you to Dr. Jagdish, Dr. Subramania, and the IEP Respiratory Chapter for giving us this opportunity. Thank you, Dr. Sneha and the CMC team. Absolutely fantastic work. It's really inspiring. Thank you, Dr. Grace and Dr. Karen, for sharing your experiences, and of course, Dr. Kabra, Professor Kabra, as well as Dr. Madhulika Kabra. We are really, really grateful for both of you for pioneering so much work in cystic fibrosis. We don't see as many patients in Bangalore, but I can clearly tell you that CF has varying presentations. The last 3 cases of CF that I have seen in Bangalore was a 4-month-old child who came in with DVT, sepsis, and shock, and eventually we diagnosed as cystic fibrosis. The second child was a child who had been ventilated 5 times for respiratory failure and had all the markers all along, but of course we've missed it. And a third child who also came in with pancreatitis and was referred from the gastro team and had also liver enzymes raised. And so it was an entirely different spectrum. So it was not pulmonology, it was other organ involvement at very young ages. And hence, I think it's great to be sensitizing our doctors and all of us through this kind of work. I also think Dr. Kabra and team with the Cystic Fibrosis Parental Group, that they have a meeting every year and call all of us physicians in Delhi. It's also a great initiative by Dr. Kabra's team. I've also had opportunity to work with parents here in Bangalore and surrounding areas, and they are very much keen to the parental support teams are very, very important. And sometimes we forget psychosocial support is extremely important for most of our CF kids. I think 90% of them are not covered by insurance, and that also is a big challenge for all of us doctors here, especially even in private hospitals. Even to try to give them IV antibiotics for 14 days becomes a challenge. And we hope the CF in India sees a great future. Thank you all.
Thank you. But I'm coming to the last but interesting part of the session. This is the most interesting part. I have kept it as a suspense for all of you. And a winner from the audience will get a surprise gift from Dr. Jagdish Chinappa. Are you all ready? Okay. Please type in the chat box. The best person would get an interesting prize from Dr. Jagdish Chinappa. He's going to announce it in the end. Okay, type now. The first question is, does CF exist in India? I'm seeing only 3 responses. Oh my God. Only 5, 10. There are 73. There is no. All of you are typing yes. Very good. Dr. Jagdish, I don't know to whom you want to give. Please note all the chat box numbers. You are going to announce the surprise prize at the end. The next question. Should you diagnose CF early or late? All of you are earlier. Very good. Nice. The next question. Best would be at birth. Fantastic. Jagdish, note that Madan Kumar, who has written best at birth. Fantastic. The next question. Please type. Is registry needed? Okay, very good. Can I go to the next question? Is it a respiratory disease or a multi-system disease? Okay. Can the next question, can you diagnose in your newborn rounds a probable CF in your routine postnatal rounds? Yes, I can see. Very good. That means we are through the workshop. Messages. The next question. Fantastic. Very good. Now, the next question is, do you know where to refer if you suspect CF? Yes or no? Okay. Now the next question. Is it a job of pulmonologist or a multidisciplinary approach? Multi, very good. Fantastic. That means I'm coming to the last question, the most important question. This would win a bumper prize. Do you want to know more about CF? I'll tell you the answer also. Do you want to know more about CF? Only 5, 6 have answered. Some more, fast. Do you want to know more about CF? Yes. If you want to know more about CF, there is only one way. Become members of the respiratory chapter. Message to me and become members of the chapter. There is great learning and great moment for all of you. And I would open up Dr. Jagdish Chinappa not only to tell the name and also to announce the big prize. So Dr. Jagdish Chinappa, over to you for final remarks. And Dr. Karen, you want to tell something? Please unmute.
This was answered to your last.
Send my number.
Your last question, I'm not sure that I qualify for the Respiratory Society, but I would join.
We'll make her honorary member, madam.
I have sent my mobile number. Those of you who are not members of the chapter, please WhatsApp to me. It takes 2 seconds. Just 2,500 rupees. Madam, it's very cheap for the persons from US. It's less than few dollars for you. So I'm sorry, I'm just kidding with you. Now, Dr. Jagdish Chinappa would announce the prize as well as give the final remarks.
All right. So I think everybody deserves a prize. Everybody has answered correctly. So there's no question about it. But I think there was an enthusiastic young person, Madan Kumar. Can I know from where he is quickly?
Please raise your hand. I would allow you inside. Madan, please raise your hand. I don't know. Archana, can you allow Dr. Madan inside? Right? One second. I'll just allow him inside. Dr. Madan has come inside. Can you unmute yourself? And Madan, unmute video and audio.
Both.
The winner of the today's, congratulations. Dr. Jagdish Chinappa will only announce the prize.
Are you a member of the respiratory chapter?
So far, no, sir.
No, so far, no. So we'll give him honorary membership of respiratory.
Hey, Jagdish, you have made me loss of 2,500. This is unfair, yeah.
Thank you, sir.
Yes. So, Madan, where are you from?
Sir, I'm from CMC Vellore, sir.
Oh my God.
Excellent.
Okay.
Excellent.
Okay.
So I think Dr. Subramania, you have invested in somebody.
Doesn't matter.
So
Dr. Madan, we will welcome you. You will be given honorary membership for respiratory chapter because it is announced by president and I can't bypass president being secretary. So it's fine. So therefore, we welcome you to the chapter and you are the new member. So my dear friends, this takes me to the next thing that do you know that if you answer well in Respinars, you may have complimentary respiratory chapter membership also. So please be on your toes and tomorrow log in for an interesting session by Professor Annie Chang at 4:30 p.m. Indian Standard Time. Everything about cough, all about cough. She will make you stop coughing your children. Isn't it nice to watch? And that is what you need, isn't it? So therefore, I would thank all the panelists who have spent their day and night, Dr. Sneha Madam, Dr. Kabra sir and team, and everyone, and all the participants for a wonderful evening. and the 2 successive evenings. And what was nice to see was that there was no dropout of numbers, and they participated on both the days. Please give your remarks to my number that I have done, and please give your constructive as well as suggestions that you would not like to put in the chat box, but critical. They are also important for improving our Respinars. Doesn't matter. Feel free and put any of your comments, constructive or otherwise. We are always there to help you out. So see you tomorrow at 4:30 for the subsequent Respinar. And I request all the panelists to just say hello, bye-bye to everyone.
Bye.
And
Thank you.
you can tell
Bye.
bye-bye.
Hello, thank you.
Bye.